You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for January 27, 2023. This week, exercise as therapy for AFib, drugs have more than one effect, artificial intelligence bots and the future of medicine, and the good and bad news about prognosis in patients with heart failure. First topic is exercise. The Adelaide group of electrophysiologists, led by Prash Sanders, is at it again. This month, the increasingly prominent journal JACI P has published results of the Active AFib randomized controlled trial. Active AFib screened patients with symptomatic AFib who were referred to 3 tertiary hospitals to participate in a pragmatic trial of an exercise intervention. They screened 369 patients and randomized 120 patients, so right off the bat, you know this is a select group, and kudos to the authors for including the screened versus randomized patients. By the way, as an aside, this is a really important thing to look at when starting to read a trial because it bears on how representative the study patients were to normal patients. First author, Dr. Adrian Elliott, is an exercise physiologist, and the exercise intervention in the Active AF trial was carefully tailored to the specific patients. Some of these patients were older and retired, others were younger and still working or had family commitments, so they needed different strategies. All patients in the exercise arm had a baseline VO2 max test, which then guided the parameters of the exercise program, which was supervised initially in clinic and then also included home. And this included high-intensity aerobic intervals. For the first 3 months, patients did weekly supervised exercise visits. Then these were every 2 weeks. They also had an exercise prescription for home-based activity with the goals of getting up to 210 minutes per week of exercise. The control arm got standard advice on exercise with goals to reach 150 minutes a week of exercise. And then they had repeat visits at 3 months to reinforce the advice on exercise. Now remember, this group at Adelaide is known for their risk factor modification. So the control arm is going to be pretty good in Adelaide. Patients were on average 65 years old, 75% were male, and they had a baseline BMI of 30 to 31. The co-primary endpoint in the trial was AFib recurrence off antiarrhythmic drugs without ablation, and the other co-primary was symptom severity score. The results of Active AF were positive. By 12 months, freedom from AFib was achieved in 40% of patients in the exercise group and only 20% in the 60 patients in the control group. That hazard ratio was 0.50 and it was statistically significant. There was also a statistically significant improvement in AF symptom score, although this barely met significance. VO2 max, which is a measurement of exercise performance, improved in the exercise arm, but interestingly, weight, BMI, and blood pressure did not change. Now that's sort of important because A, it reinforces the notion that weight loss takes more than exercise, and B, the reduction in AFib recurrence in this trial occurred with exercise alone, not any objective evidence of risk factor modification. Also notable, though, the same number of patients in both arms ultimately went on to have PVI, AFib ablation, which speaks to the modest effect size. I would add, however, that supplemental figure 1 found a strong trend that overall AFib survival with drugs and or ablation was better in the exercise arm. So it seemed like the added fitness adds to the other rhythm control strategies. Okay, my comments. I have to first disclose some biases. First, I'm friends with Adrian and Prash and others on this team. Second bias, I strongly believe that AFib ablation in our fee-for-service model in the U.S. is wildly overused. And I don't want anyone to think that TWIC podcast hides its biases. So here goes. We should first set out that randomization in a trial is a much better way to study the effects of any intervention, especially exercise, than is an observational design. And of course, that's because observational designs will have severe problems with selection bias. Healthier patients are far more apt to exercise and gain fitness, and it is likely those factors, not just the exercise itself, that may lead to lower rates of AFib. The bottom line on the results, this is a positive trial. It showed statistically significant and clinically important reductions in the primary endpoint. Add to that the fact that exercise has essentially no adverse effects and has many other positive health benefits. Therefore, this is an extremely valuable addition to the AFib literature. Now, another clarifying fact. The issue of AFib being increased in endurance athletes does not pertain here. It doesn't. That association occurs in folks who insist on years and years of intense endurance exercise. These are people who could be said overdose on endurance sport. The goal weekly dose of 210 minutes per week of exercise in active AF amounts to an easy day of training for many of the people who get AFib from too much exercise. But there were limitations of this trial. First, let's go into the external validity issues. The generalizability. The authors clearly state that they excluded 250 patients of the 370 that they screened. Many patients just refused. Others had orthopedic issues that precluded exercise. So, as the authors write, this is a select group of patients, and structured exercise is not going to work for all patients. Another external validity concern. This is a single group study. This group is intensely interested in using risk factor modification to improve AFib outcomes. And Adrian Elliott is a force of nature. He's a talented and motivated leader. I'd listen to him if he said, do this amount of exercise. In other words, this group is full up of champions for exercise and fitness, which is an important factor for translating this evidence because it's a question whether this scales to places with less enthusiasm for fitness, like, say, 95% of the U.S. Now to the internal validity question, so that is trial conduct. Now, this trial is obviously unblinded, so I don't think we can put much weight into a quality of life questionnaire. In fact, I'm not sure quality of life should be used in any trial that isn't blinded. The arm with the more care will always tend to feel better. That's because caring signals are important in improving quality of life. Caring signals should never be discounted. Another issue, and again the authors highlighted this in their paper, was the lack of continuous monitoring for AFib. When you measure AFib recurrences as an endpoint, you like to have continuous loop monitors. But I totally understand the limits of funding, right? These are expensive, and there's a tension between doing an imperfect trial or not doing any trial. Now, I've seen some raise the issue of performance bias, meaning patients in the exercise arm benefited from more interactions with caregivers. Now, the authors addressed this concern by saying, well, the bias of increased interactions in the exercise arm may have helped reduce AFib, but that could have been countered by the increased chance to pick up AFib. But, I'd argue it a different way. I'd say performance bias was the point here. You're studying an intervention of more involvement with caregivers versus less. I don't actually see performance bias in this study as a problem. It's unlike the East AF NET trial. In East AF, remember, the question was, does maintenance of sinus rhythm improve outcomes over standard of care, which was mostly rate control? And East AF found that early rhythm control led to a reduction in hard MACE outcomes, major adverse cardiac events. These were CV death, stroke, heart failure, and ACS. Well, in that trial, in East AF, patients in the early rhythm control arm had many more interactions with healthcare providers And it could have been those interactions that led to better outcomes in things like heart failure and ACS and stroke. And I say that because the actual difference in East-AF and AFib in the two arms was really minimal. And if you want to show early rhythm control is better, the control arm should have the same amount of care. And you have to show a larger difference in AFib in one arm if AFib is the hypothesis driving the benefits. Otherwise, there are other factors besides AFib that is reducing non-AFib related outcomes such as heart failure, stroke, and ACS. Okay, the future directions from active AF. This exercise fitness signal ought to be studied further. Why wouldn't this scale to cardiac rehab clinics? I mean, the infrastructure is already there. Such clinics are well suited for this. I'd love for the government to fund a multi-center trial randomizing AFib patients to cardiac rehab-led exercise versus standard of care. Think of the benefits that we may get from that. So the take home for your clinic today or tomorrow or the next day, I think exercise is way underutilized. I routinely tell patients that 15 to 30 minutes of exercise that leads to sweating is like a heart pill. It should be taken every day. Now I can tell my AFib patients that there is a chance that exercise may help reduce AFib. Along with weight loss, sleep apnea treatment, and alcohol reduction, there is a chance that their AFib might be vanquished without obliterating atrial myocardium. And the best argument to incorporate these findings is, even if this isn't replicated in a big trial, what are the downsides? Even if AFib remains, there are still huge benefits from gaining fitness, especially for 65-year-old patients who have a BMI of 30. All right, next topic, drug effects. This involves a drug complication that I did not know about. The new wonder class of drugs called glucagon-like peptide 1, GLP-1 agonists, specifically semaglutide, have been shown to have a possible harm, and that's the worsening of diabetic retinopathy. Now, I highlight this meta-analysis of GLP-1 agonists, which was published in the Diabetes and Metabolic Syndrome Journal, and it was also covered by journalist Marlene Busco for two reasons. First, the GLPs are a hot new drug class. They're being used for both diabetics and patients with obesity, and so we ought to know about safety signals, especially since cardiologists treat a lot of patients with diabetes and diabetic retinopathy. And the second reason is it's always good to remember that drugs may block one or two channels, or in the case of amiodarone, many channels, but their effects are not limited by this one action. Please do read Marlene Busco's summary. It's really good. The meta-analysis combines 6 of the GLP-CV outcomes trials and the ones that included and evaluated diabetic retinopathy. Now, while it's well established that these drugs reduce MACE in patients with diabetes, this meta-analysis found that semaglutide increased the rate of diabetic retinopathy by a hazard ratio of 1.73, 73%, and the confidence intervals went from 10% higher risk to 2.7x higher risk. Now, the authors also did something called a meta-regression, which is a type of statistical analysis used to study the relationship between different variables in these large groups of studies. The purpose is to try to understand how different factors might be affecting the results of different studies. For instance, a meta-regression might be used to look at how different study designs or sample sizes or other factors are influencing the results of studies on a particular topic. Meta-regression basically uses the study results rather than the patients as the measurements to plot on a graph. The goal is to identify patients or trends in the data that can help researchers understand the underlying causes of the results they are seeing. By the way, most of that explanation comes from a chatbot. If you haven't used this yet, you are behind, and more on artificial intelligence chatbots in a bit. Well, the meta-regression of these studies found the following signals. First, the A1C reduction correlated with both MACE reductions and the increase in diabetic retinopathy. The change in diabetic retinopathy was predominantly found for subcutaneous semaglutide given for more than 1 year, and it was found to increase with reductions in A1C. So the more A1C reductions you got, the more likely there was to be an increase in diabetic retinopathy. And the authors wrote this, quote, "When evaluating semaglutide alone, the effect on worsening retinopathy was not associated with drug exposure alone or with the oral semaglutide. Rather, there was a correlation of worsening diabetic retinopathy that associated with longer trial duration and more reductions in A1C. Now, the reassuring part of this analysis was that the absolute reductions in cardiac outcomes was far greater than the increases in diabetic retinopathy. And previous studies in this field seem to suggest that the proportion of diabetic retinopathy complications with this drug were greater among patients who had a history of retinopathy at baseline." Okay, so two messages. The specific message is don't shoot from the hip. If you have an overweight diabetic patient that you're thinking about prescribing semaglutide to, because you read New England Journal of Medicine, for instance, think about diabetic retinopathy. If the patient has it, chat with the eye doctor or defer to the diabetes doctors. But the larger message is that even though a drug blocks one pathway, their effects can be complicated. Always remember that most trials are 2 to 4 years in duration, and most regulatory trials are designed for efficacy, not safety. When we use drugs for longer periods in trials, there are both known unknowns, things we know we don't know, and there are unknown unknowns. And these unknowns may be relevant given the recent news regarding this drug's effects in young people with obesity. All right, next topic is something different. ChatGPT can pass USMLE exam questions. Now, I'm going to take some of this discussion from a preprint published on this AI's tool's ability to answer medical test questions. The preprint is already accepted for publication in the journal PLOS Digital Health. But first, I need to set out that everyone needs to know about ChatGPT. This is not Mickey Mouse. ChatGPT is a large language model developed by OpenAI. Large language models are different than previous deep learning models which simply recognize patterns. Get this, it's ridiculous. LLMs, large language models, are trained to predict the likelihood of a given sequence of words based on the context of the words that came before it. And if trained on large amounts of text data, they can generate novel sequences of words never observed previously by the model, and these words typed out before your eyes are plausible. Anecdotal usage indicates that ChatGPT exhibits evidence of deductive reasoning and a chain of thought as well as long-term dependency skills. Here's what one of the smartest persons on the internet says, and someone you should be following. This is George Mason University's economics professor Tyler Cowen, who wrote on his blog Marginal Revolution, quote, "In only a few years, these models have gone from being curiosities to being integral to the work routines of many people I know. This semester, I'll be teaching my students how to write a paper using large language models." He goes on, "At some point, GPT may substitute directly for some of my writings. I expect I will invest more in personal talks, face-to-face, and also things that involve charisma. Why not?" Tyler goes on, "Well-known established writers will, of course, be able to ride it out for long enough, if they so choose. There are enough older people who still care what they think as named individuals, and that will not change until an entire generational turnover has taken place." He says that he expects the entire calculus is very different for someone who is 20 years old. Today, Professor Cowen goes on, "Those who learn how to use GPT and related products will be significantly more productive. They'll lead integrated small teams to produce the next influential big thing in learning and also in media. Most current contributors will miss that train almost entirely, just as so many people miss the importance of the internet for learning and also for media." Okay, in the preprint, a group of people from Ansible Health, this is a company that manages homebound patients with chronic lung disease, they tested the bot's capabilities in taking the USMLE exam. In fact, get this, the bot wrote the abstract and results sections of the actual preprint, and it contributed large parts of the introduction and method sections. This would be like multiple authors who contribute to a paper. And for each step, the researchers prompted the chatbot in 3 ways. First, it was given a theoretical patient sign and symptoms and asked to pontificate on what might be the underlying cause or diagnosis. Next, After the GPT was refreshed to eliminate potential bias from, say, retained information from the previous exercise, it was given the questions from the exam and asked to pick an answer. After again refreshing chatbot, the researchers asked it to, quote, please explain why the correct answers are correct and why the incorrect answers are incorrect. Then the answers were reviewed and scored by 3 board-certified licensed physicians, and the chatbot did well, getting answers in the 50 to 60% range overall. Now, of course, they only tested this on a fraction of the test. They couldn't use questions that used images or sounds. My comments. My comments are, I don't exactly know what to say, except for I have the same feeling now about these AI models as I did when sitting in the VA clinic in 1990, playing around with this new thing called the internet. Clearly, though, medical licensing exams are going to need to change. I mean, silly memorization questions that an AI bot can answer will need to sort of cede to questions that only humans can do. Okay, next topic, heart failure prognosis and the implications for new therapies. The European Heart Journal has published a nice paper on heart failure prognosis. The results explain a lot of what I talk about here on the TWIC podcast. This was an observational study taken from a Danish registry. The first author was Jonas Brun. They included just over 100,000 adults who were free of cancer and had a heart failure diagnosis between 1997, way back, and the end of 2016. The purpose of the paper was to explore competing causes of death in patients with heart failure. And this is a very important topic because as heart failure survival improves, this may increase the risk of other things like cancer because people, as they live longer, get more competing causes of mortality. And data sets like the National Registry in Denmark allow for looking at temporal trends like this. Also, an aside is that this is a really appropriate use of observational data, unlike the many studies that try to simulate randomization from non-random comparisons. Think users and non-users of hormone replacement therapy to prevent cardiovascular disease in postmenopausal women, for instance. The authors report 2 main findings from this Danish registry study. One was that the incidence of cancer 5 years after a heart failure diagnosis did not change over the 20-year period. It remained stable. The other finding was that 5-year cumulative incidence of survival for heart failure patients increased with the advancing calendar year, and it went from 56% back in 1997 to 2001 to as high as 74% between 2012 and 2016. Both of these results surprised me. I would have thought cancer incidence would have increased, but the improved survival after a heart failure diagnosis is a super important observation. It's important because it helps explain a lot of the non-significant findings in recent years that we're seeing in heart failure trials. Danish trial, ICD therapy and non-ischemic cardiomyopathy, for instance, was non-significant. Many of the HFpEF trials are non-significant. And even the ones that were significant are driven by things like heart failure hospitalizations, not CV death or all-cause mortality. Recall that's different, though, than the early trials in heart failure. ACE inhibitors, beta blockers, spironolactone all had substantial mortality reductions as an endpoint. But the newer heart failure trials are mostly positive only because they reduce some non-fatal surrogate outcome. In sum, the good news is that we do a lot better treating patients with heart failure. The bad news is that given our fixed human lifespans, it's going to be much harder for new therapies to make much of a difference in mortality. So the new frontiers of heart failure care may come in better palliative care. Mortality may no longer be the best endpoint of heart failure trials. And actually, adopting therapies that improve the quality of life of heart failure patients may become a huge positive and major advance. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, friends, if you like this podcast, please take the time to give us a rating on whatever app you use. Even a 1 or 2 sentence review goes a long way to help others finding the podcast. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.